Hello everyone, I am Dr. M V Chandrakant. I am a medical oncologist in Narayana Hospital, Kolkata. I would thank the organizers for the opportunity. Today, in coming 10 minutes, I would speak on HER2 positive metastatic breast cancer on a novel molecule pyrotinib. So I'll be presenting two trials. One is a phase 3 study and another one is a phase 2 study, both on pyrotinib. It is a novel Chinese HER2 inhibitor. So the phase 3 trial is head-to-head comparison of K-pyrotinib versus K-plapatinib in trastuzumab treated patients of metastatic breast cancer. So a HER2 positive metastatic breast cancer post trastuzumab progression is a real challenge, and we have very few options available with us. One is TDM1 and the another one is lapatinib. The other options which we have heard of are trastuzumab deruxtecan, tucatinib, pyrotinib, and neratinib. Well, if you look into the four HER2 TKIs which we have lapatinib, neratinib, pyrotinib, and tucatinib. So if you look into lapatinib and tucatinib, they are reversible HER2 inhibitors, and they are confined to HER1 and HER2. Whereas neratinib and pyrotinib are irreversible HER2 inhibitors with a broader spectrum of HER2 inhibition, that is HER1, 2, and 4. So the moment it becomes irreversible, it becomes more potent. Also, the side effects become more. And you can note that even though pyrotinib is irreversible, it has HER1, 2, 4 activity, it is not yet FDA approved. Well, coming on to the first trial, that is the phase 3 study. It is in metastatic breast cancer patients post trastuzumab progression. So it is 1:1 randomization of 135 odd patients in each arm. The randomization is K-pyrotinib versus K-plapatinib. The dose of pyrotinib is 400 milligram once daily. The doses of K-plap are as per the standard trials. The primary endpoint is progression-free survival, secondary endpoints being overall survival, response rates, and so on. If you look into the baseline characteristics, well, the characteristics are fairly well matched. What you can note is, going on to the lowest most row, you can note that nearly 40% patients have not received any treatment in the first line metastatic setting, and another 40% have received only one line of treatment, and just 15% patients have had 2 lines of treatment, even though by definition it includes patients with at least 2 lines of therapy. Nearly 80% patients were sort of a good subgroup, having received no treatment in metastatic setting or at least 1 line only. So it is selecting out good subgroup of HER2 positive patients. And if you look into the trastuzumab resistant patients, it's only quarter of patients in each arm. Well, the study is a positive study. The study met its primary endpoint of progression-free survival, crossing 1 year, doubling of PFS. So seeing HER2 TKI giving 1 year of progression-free survival is phenomenal, with a good hazard ratio of 0.39. Well, the overall survival was also significant in the pyrotinib arm. Again, the hazard ratio being 0.69. And just to summarize the results, progression-free survival 12 versus 12.5 is 5.6, and overall survival not reached versus 26.9 months. So the overall survival and the progression-free survival were preserved in all the 3 lines of therapy, whether it is 0 line, first line, or second line. And then in the trastuzumab resistant subgroup, the overall survival in the pyrotinib arm was not that significant, whereas the progression-free survival was well preserved. So the authors concluded that in patients of metastatic HER2 positive breast cancer post trastuzumab capecitabine in combination with pyrotinib, in comparison to K-PLAP, had significant improvement in progression-free survival and overall survival. In fact, there was doubling of PFS, and the PFS was more than 1 year. And the overall survival results were also promising that showed statistical significance. So this brought capecitabine plus pyrotinib being a standard of care in the Chinese population, having a head-to-head comparison with K-PLAP. Well, and the good points of the trial are it's a well-conducted randomized controlled trial. It was a positive trial addressing relevant endpoints, progression-free survival, and overall survival in trastuzumab-treated patients. Well, if you look into the shortcomings, so it was a small study, and none of them received TDM1 or pertuzumab because there was no access to these drugs in Chinese population. Even though it was a multi-center study, there was no central lab confirmation of HER2 status. 40% patients actually received no treatment in the metastatic setting, just saying that these are a good subgroup of patients. And there was no overall survival benefit in the trastuzumab resistant population. And pyrotinib is not yet FDA approved. So the take-home messages are HER2 post-metastatic breast cancer post-trastuzumab. If TDM1 is not feasible, capecitabine plus pyrotinib is better than capecitabine plus lapatinib. Better PFS, overall survival. However, diarrhea, HFS are worse. Coming on to the second study, phase 2 single-arm study of cape pyrotinib in HER2 positive patients, specifically looking into intracranial responses. Two cohorts, cohort A being without cranial artery and cohort B being post-cranial artery, cape and pyrotinib as per standard doses as per the previous trial. Objective response rate was the primary endpoint. CNS responses. Again, cohort A was sort of untreated patients, no prior HER2 TKI was given, whereas cohort B was post-RT, multiple lines treated. So, if you look into the intracranial responses, 75% intracranial responses in the arm which had not received RT, and 40% responses in the arm which had received RT. And even the extracranial responses were also good. So median PFS 11.3 months in cohort A and cohort B 5.6 months. And the adverse events were as per the previous trials, diarrhea being present in 92% patients and grade 3 around 25%. And the other side effects being liver derangement, hand-foot syndrome, and so on. So capecitabine plus pyrotinib has excellent intracranial response of 75%. So coming on to the well-conducted study, specifically addressing this subgroup of patients, again, TDM1 pertuzumab was not used. And these are the approximate responses of different HER2-directed therapies. We can see the lower down, trastuzumab, deruxtecan, and pyrotinib having the best intracranial responses. So the take-home messages are pyrotinib has excellent CNS activity. Intracranial responses are 40 to 75%. Diarrhea is a matter of concern. It is best to use before radiation and earlier lines of therapy. In the real world data says that pyrotinib works better in patients with low tumor mutation burden. Thank you.